Hi, everybody. Good afternoon. I hope you are having a good week so far. Yes, today is the middle of the week, and it's that day, as Bon Jovi says, we're halfway there. Happy Wednesday, everybody. Let's learn something new today. I'm Dr. Mary Ambach. Unfortunately, my partner, Dr. Rogers, is not able to attend our webinar today. We do these webinars every second Wednesday of the month, and we choose special topics that we think might be of interest to you, our viewers. Our topic for today is herniated discs, which is a fancy term for bulging discs. My patients always ask me, what's the difference between the two? They're the same thing. We want to talk about herniated discs and if cell therapies can help with this condition. Herniated disc or degenerative disc condition accounts for about 30% of the cost for chronic low back pain. And as many of you know, chronic low back pain is one of the major musculoskeletal issues that we see in the clinic. And it's responsible for the highest burden of disability right now. So this topic is not only prevalent, but it's also very consequential. It's a very costly musculoskeletal problem. So Dr. Rogers, as I said, is not joining us today. He is the founder of San Diego Orthobiologics Medical Group. We are both board certified in physical medicine and rehabilitation, and we're both fellowship trained in spine and interventional pain management and regenerative medicine. Our interests is in regenerative medicine, which is based on the concept that our bodies have the ability to heal themselves. And we base our treatments on that premise and to do treatments to help your body heal naturally. So we've got decades of experience in performing regenerative procedures. We have published in book chapters and journals. Currently, we are participating in clinical trials for regenerative therapies. We have a knee osteoarthritis stem cell study that's ongoing, and we also have a study on degenerative discs for low back pain using platelet-rich plasma and bone marrow concentrate. So let's look at the anatomy first. If you look at the picture on the right side of your screen, you see the bones that comprises the spine, and that's called the vertebral body. In between these bones, you see the discs, which acts as a cushion between these two bones, the intervertebral bodies, and we call this intervertebral discs. And the discs is composed of an outer strong cartilaginous material called the annulus fibrosus and an inner gel-like material called the nucleus pulposus. Whenever your discs weakens, the outside portion of the discs becomes weak and it tears out, this inner gel-like portion bulge out into the canal, and this can cause compression or irritation of the surrounding nerves in your spine. Sometimes chemicals can leak out as well from these discs that are bulging and can irritate and inflame these nerves or the surrounding tissues, a condition what we call chemical radiculitis. So all these symptoms of all these changes of disc bulging and nerve irritation can cause you symptoms of localized low back pain or neck pain, muscle spasms, pain with prolonged sitting or prolonged standing, bending forward. And sometimes it can refer down or radiate down to your legs or to your arm if there's nerve irritation. And patients notice as sciatica when it goes down to your legs. The cause of bulging disc or disc herniation is due to age-related degenerative changes or due to injury. As we increase years to our age, our discs, which are our cushion, loses some of this water that keeps it pliable. So we lose the hydration, the disc gets drier. That can make it more prone for tearing out or for degeneration. And then we lose some of that height and the disc becomes collapse. And when that happens, it can, as I said, irritate the surrounding nerves around the disc bulge. It can also cause increased pressure in the joints, which are right next to your discs. And that can lead to what we call facet joint osteoarthritis. So the combination of the arthritis in the joint and the bulging of the discs can cause a condition which we call spinal canal stenosis or nerve canal narrowing, and that can cause additional pain to your back. There are also some risk factors that makes you more predisposed to having a bulging disc or a disc herniation. And some of this will include activities or sports that involve repetitive bending forward, repetitive twisting, pushing, pulling. Genetics can play a role as well. If your mom or your dad have history of disc herniation, you're more likely to have it as well. And believe it or not, smoking can also make you more at risk for having disc bulging. And the reason being, the smoking can constrict your blood vessels. And when that happens, there's decreased blood flow to the discs. So the nutrients that goes into the discs is diminished. Thus, it can't repair itself that much. So if there's one thing that you can do, it's to stop smoking. That will help not only your back pain and spine pain, but a lot of other health issues. There's different classifications that we use to classify disc degeneration in the MRI. So this is one of them. It's grades 1 to 5. Sometimes it goes until 7. The left side, which is the lower number of grade, is a healthier discs. And as you go to the right side of your screen, you have a more degenerated discs. So as you can see, there's a white signal of the center of the disc which corresponds to the water or the gel in your discs. And as it gets degenerated, you lose some of that water and it becomes dark. You can see the disc becomes darker as you go to the right side of your screen here. You can also notice that the disc height becomes diminished or becomes more squish, as my patients would say. And you lose some of that height, and you can also see some disc bulging as your disc becomes more degenerated. If you look at grade 2 here, you can see the back of your disc is nice and straight, but if you look at grade 5 here, you can see a disc that's bulging out. So different kinds of classification. Most patients lie in the grade 3 to grade 4 category. The more severe ones are in the higher grades. And the standard treatment for this condition is a good course of physical therapy to maintain spinal flexibility and spinal strengthening, anti-inflammatory medications to keep the inflammation at bay, maybe some medications for severe pain. And if you fail this, there's different kinds of injection therapies, most specifically, injections into the epidural space, which you probably know as epidural steroid injections. And if you fail all these treatments, there are several surgical interventions for this condition. The problem with most of these treatments are they are designed for symptomatic relief or pain relief. And there is really no current adequate treatment for patients who have failed standard treatments while waiting for a surgical intervention until now. So that's where orthobiologics or cell therapies come in. Orthobiologics, as you know, they are cells or tissues or substances from the cells that are designed to facilitate the healing of our body and repair damaged tissues. This can include your platelets, which is the cell that we are interested in for PRP or platelet-rich plasma, stem cells, other proteins and growth factors that are involved in the healing process. So platelet-rich plasma is the most common cell that we use in the clinic. It is a concentrated amount of platelets within your plasma, which is the blood fluid. And we can concentrate your cells up to 8 times, 10 times more than your body concentration. And we want to do that because we want to have a supraphysiologic amount of growth factors, because it's these growth factors that are involved in your healing process. What the platelets do is they stimulate a blood vessel formation so that more nutrients can get into that area to help with healing. They facilitate tissue regeneration. They facilitate stimulation of other healing cells to come to the area, and they also help with inflammation. There's different types of PRP. There's probably about 20 different kinds of repairing your PRP, or even more. These are just some of them. And depending on your orthopedic condition, we tailor the kind of PRP depending on what you need. For example, the yellow PRP on the right here is probably something that we will use for your spine, or the one on the left here, the red PRP, is probably something that we use for certain types of tendon injuries. So there's different kinds of preparing your PRP. We use different kinds of centrifuge machine. We also have the ability to do a manual preparation, and that's how we can personalize and tailor your biologic treatment depending on your condition. So we're not using just one centrifuge for all our PRP treatments, and I think that's what makes us unique, is we can customize it. If you look at the upper right side of your screen, that is a laminar hood machine, and that is where we process all our cells and biologics, and that purifies the air and prevents contamination of your cells and tissues. We also have a cell counter, which is the right lower picture, wherein we're able to determine how much platelets we are giving to you for your treatment. Stem cells is the other kind of cells that you probably hear about when you're talking about regenerative therapy. We derive our cells from either the bone marrow or the fat. For the spine, we use bone marrow derived cells. Stem cells are unique cells because not only do they have the ability to replicate or renew themselves, they also have the ability to differentiate into other cells that are needed by the body. So for the spine, we use cells that are derived from the bone marrow. We call that BMAC, or bone marrow aspiration concentrate. It's a minimally invasive clinic procedure without the need for sedation. We get the bone marrow from the superficial aspect of your pelvic bone, which is what we call the iliac crest, as you can see here in the picture. So we are particularly interested in these adult stem cells that's called mesenchymal stem cells, or MSCs. And these mesenchymal stem cells are a specific type of adult stem cells that has the ability to differentiate into the tissues that we are concerned about with orthopedic injuries: bones, tendons, cartilage, muscle cells. And so this is our focus with regards to our orthopedic treatments. Dr. Kaplan, which is this physician this researcher on the middle here, is the father of MSCs. He named mesenchymal stem cells more than 25 years ago. And these MSCs are lying right next to your small blood vessels, and they're just staying there waiting for an injury to happen. And when they are called upon to work, they get activated and they start releasing all these different molecules and chemicals that are involved in healing your tissue, in regulating inflammation, controlling inflammation, and also in fighting infections. So this is how these MSCs, or your stem cells, work. So how does these cells help with regards to your disc herniation or your disc degeneration? Well, there has been some research that showed, both in animal and human trials, that showed that these cells actually increase the proliferation of your cells in your discs. They also increase the support tissue, what we call the extracellular matrix. They improve the hydration or the water content of your discs. They decrease inflammation, and they also support tissue healing. There's also studies that shown that they actually help repair tears in the disc, or what we call annular tears. Not everybody is a candidate for cell therapy. You know, patients who have severe disc degeneration may not benefit from these cell therapies. Some studies have put out the criteria of decrease in disc space height of more than 50%, a normal disc height. So that has been what we have been adopting. If you look at your image on the left here, you see that L5S1 discs is severely diminished, and that's probably severe enough, which will not be amenable for intradiscal cell therapy. Severe narrowing of the canal that creates compression of your nerve roots is also probably will result to a not significant clinical relief from this cell therapy, especially if you start developing neurologic symptoms of weakness or muscle atrophy. That's probably something that you need a surgical intervention for, and especially a spine that's unstable. Whenever you have spondylolisthesis or abnormal alignment of your spine, that can lead to unstable spine, and that is most likely going to need some surgical intervention. So what is the evidence for injecting cells into your discs? There's a lot of studies that has been published. This is one of them, and this particular research actually compiled different clinical trials and did a systematic review and came up with a conclusion. So on your left, this is the PRP research that they have published. They compiled data from 5 different clinical trials of injecting PRP into the discs, total of 90 patients in total with a follow-up of up to a year. And then on the right side of your screen is a research publication that compiled 7 different clinical trials, totaling 97 patients and up to about 72 months of follow-up. And their conclusion was the same, that patients who receive injections of PRP and bone marrow cells into their discs resulted in significant improvement in their pain and function with low complication rate. This is one of the earlier studies, excuse me, on using a platelet-rich plasma for disc degeneration. And what they did is they injected PRP into the discs of 47 patients, just one-time injection. And they compared this with the group wherein they injected contrast material. And they have shown that the PRP-treated group improved in their pain, in their function, and in their patient satisfaction. And this was maintained up to 2 years. And in fact, they did a follow-up study on this initial one, and they followed the group of patients that received PRP for up to 9 years. And what they saw was that these PRP-treated patients continued to have significant improvement in their pain, in their function, and their patient satisfaction up to 5 to 9 years. So which is pretty significant. Don't know of any other treatments that are available right now that can lead to that long of a pain relief and improvement. We published our own data back in 2018, wherein we use PRP for the less degenerated discs, and we use bone marrow cells for the more degenerated discs. And we found that at 18 months, 93% of the patients that were enrolled in the study showed more than 50% of pain relief and improvement in their function. 80% of our patients who were enrolled also decreased their pain medication use. All of the patients that were enrolled were able to avoid surgery, and we didn't see any adverse effects or complication. No one was hospitalized, no one went to the ER, or no one had to undergo surgical intervention, and no one had infection. This is one of the patients that received the treatment. It might not be too obvious, but if you look at where the arrow is pointing, there's a little white line at the back of the discs, and that is a disc tear, or what we call an annular tear. And after 6 months, when we did a repeat MRI on this patient, that tear resolved. Now, eventually, annular tears resolved if without treatment, especially small annular tears like this, but it usually takes 18 months or even longer for them to resolve. And the PRP in this case just facilitated that healing process. This is a bone marrow cell study wherein instead of PRP, they injected bone marrow cell therapy to patients who have disc degeneration. And the important thing in this study is that all these 26 patients who were enrolled were all candidates for surgery, whether that's a surgical fusion or a disc replacement. And their finding was that there was an average improvement of 73% with regards to their pain and 70% with regards to their function. Out of the 26 patients, 6 patients decided to proceed with surgery at 3 years. And when they followed with these patients who underwent surgery, only 1 of them had an improvement. And when they compared these patients that underwent surgery with the patients that did not undergo surgery, they did not show any clinically significant improvement between the 2 groups. Another finding was that they did MRI on the patients, most of the patients that were enrolled in the study, and 40% of those patients that had gotten the MRI showed an improvement in the disc degeneration at 1 year. So as you can see, the results from these procedures are not immediate. It takes 4 months, 6 months, even up to a year in some patients. But these are slow, gradual improvements that you will notice over time. There's more studies. If you like reading these clinical trials, you can go to our website, www.sdomg.com, and then you can click on the resources, which is in the top right of your screen here, and then go down to research, click on research, and it will list all the different biologics that we use with the studies that are associated with them. And if you click on those title of the studies, it will send you to the link so that you can read the whole research. So for those of you who like reading things like this, we have a lot of things for you to read in our website. I am involved in another ongoing clinical trial, which is a multi-center study in the US. There's 4 centers across the US that is involved in this study. Total of 60 patients. And basically what we want to do is we want to compare PRP and a bone marrow for disc disease. So there's no study that has yet compared both of them. So this will be a very important landmark study. And our goal is to determine which disc conditions respond better with PRP, or which disc conditions respond better with bone marrow for disc disease. So I will keep you posted for that. Right now, we're probably about 8 months into the study. We're planning to follow these patients for 1 year. And so that's an exciting study that I will share with you once we have the results. There are other studies wherein instead of injecting the cells into the disc itself, they injected the cells in the space around the disc, what we call the epidural space. It's similar to when you receive epidural cortisone injection. It's a similar procedure, but instead of injecting cortisone, we're injecting your PRP. And in fact, there's probably about 6 to 7 clinical trials that I know of that has published results on this injection. These are just 3 of them. And you can see there's 250 patients in one study with a 2-year follow-up, another with 470 patients with a 2-year follow-up, and then a smaller study, which is the pilot study that used 10 patients, 3 months follow-up. But they all, their conclusion was that these patients who were treated with an epidural PRP actually improve these patients' symptoms, both of their low back pain and also their sciatica or their nerve root irritation. So another question that you might be asking is, are these treatments safe? There's hundreds of research that has been published over this span of the last 15 years or so regarding the safety of these biologics. especially platelet-rich plasma and bone marrow concentrate. For the spine, there's studies that show safety clinical studies up to 2 years, bone marrow up to 6 years. That's systematic review research that I talked to you about. Analyzed 90 patients and followed them up to 1 year, and only 2 out of those 90 patients had an adverse effect of tingling numbness in their leg, which resolved. And for the bone marrow concentrate, that research had a total of 97 patients, follow-up up to 5 years, and there was only 1 patient that had an adverse effect, and this was that the patient experienced disc bulge following the treatment. Now, they weren't sure if this disc bulge was a natural progression of the degeneration of the discs, or if the patient sustained a new injury that created the disc bulge. There's also 1 published case report of an infection into the disc, which they call spondylodiscitis, and they found that this is from a bacteria that's naturally in our spine or in our discs, and they also see that whenever they do spine procedures or surgeries in the spine. That's after using a certain kind of PRP. The patient also had other medical comorbidities, so it is unclear where the or what predisposed the infection. But nevertheless, these procedures are not without risks, and it is important to choose your physicians who will perform these procedures and make sure that they have adequate experience in using these biologics, and also in performing the procedures itself. Make sure that they're done under imaging guidance, whether that's ultrasound or fluoroscopy. For the spine procedures, we use predominantly for fluoroscopy, which is this machine behind me here. It's a live X-ray machine. And make sure that they do it in a clean, safe, sterile facility to avoid any side effects of infection or complications. So I think that's the end of our slides. So we can open the floor up for questions for those of you who have any questions regarding this topic. I'm going to stop my share so that I can see your questions that you have typed. And let's go to the first question here. Okay, hello, Doc. How long does the bone marrow procedure for the disc disease last? Yeah, that's a great question. With regards to the studies, the longest study that was published that I can think of is 3 years. Our clinical experience actually is anywhere from 2 to 4 years that it can last. At least based on my clinical experience, the patients that I've injected bone marrow cells on usually do not have to repeat the procedure. Patients that had PRP, some of them might need a repeat injection in a couple of years, but some patients did not. So one difference between the two, though, that I've noticed is that patients who received bone marrow cell therapy had a quicker response from the procedure than the PRP. But either of the two cells actually have good, adequate data to support the use of it. Okay, so let's click that as done. Next question, do you also inject facets if DJD? Yes, in fact, most, if not all of these patients that have a degenerative discs also have degenerative joints. Because if you think about it, the joints and your discs support the spine. And if the disc is not 100%, all of that load is transferred to the joint. And now you have a joint that's also worn out or degenerated. So almost always is the case that you do have both. And if we do have the bone marrow cell therapy and we're performing disc therapy, most of the time we inject the facets as well. Okay, let me click that as done. Next question, how often do you need a new MRI after the PRP procedure is completed? So, all of you who have seen me in the clinic You probably heard this from me. The imaging studies don't always correlate with your MRI, right? We have patients that's got severe degenerative disc, severe spinal stenosis in their spine, and they don't have any symptoms. Or if they do, they have minor symptoms. On the other hand, I have patients that has mild disc bulges and mild arthritis, and they are in a lot of pain. So MRIs are usually not a good indicator of patient's function. Functional outcome measures do. So that's really what we monitor. We have a data biologics app wherein we can track our patients' progress, and that's what we monitor to see if these patients are effective. But with regards to the MRI, if we want to see any changes from a cell therapy injection, that usually doesn't happen until a year later. So that may be the earliest that we can get an MRI if we want to see if there's any changes in the discs or in the joints. And even if there's none, again, as I explained, we're more interested in your functional outcome rather than what your MRI looks like with regards to efficacy of these treatments. All right. Next question. If one is on the blood thinner, how long prior to the procedure would you have to stop taking, and how soon after can start taking again? So the blood thinners have different half-lives, so it depends on what blood thinner you're taking. Most of the time, we do stop them 1 week prior to the procedure and 1 week after the procedure. Patients who are on blood thinners, especially patients who've got heart conditions, we get clearance from your primary care physician or your cardiologist first. So don't stop them on their own. We need to get it cleared first, make sure it's safe before we stop your medications. But a good question. Also, some of these blood thinners or anti-inflammatories can affect your platelets. So that's one more reason why we stop it, aside from the bleeding side effect. All right. Next question. Do you treat degenerative disc disease at the T-spine? I personally don't. I know I talked about low back pain a lot because this is what most of the research has covered. And also it's just more common than a thoracic pain and cervical pain. There's probably only 2 physicians that I know in the country that does discs injection in the neck. It's a fairly complicated, more complex procedure. And I don't do those procedures. There's not a lot of data that has been published regarding disc degeneration in the neck and in the mid-back. The approach is also complicated. I think the reason why we don't see a lot of these patients with disc pain from degenerative disc disease in the T-spine, in the thoracic spine, is because it's a very stable portion of your spine. You've got the ribs that support it. So it's very stable, and it's a less common pain that we get compared to a low back and a neck. So I hope that answered your question. We actually see more facet joint arthritis pain in the mid-back rather than coming from the discs. So we need to evaluate where really is the pain coming from, because it is less likely that it is coming from the disc itself, although it's possible. Okay, click that done. Hi, are there PRP or bone marrow concentrate studies that are recruiting for severe degenerative disc disease in San Diego, California? So if you go to, so my, with regards to my clinical trial, I've already enrolled all my quota for that patient, for those patients, 15 patients. But if you go to this website, that's called clinicaltrials.gov, G-O-V. So again, that's clinicaltrials.gov, and I can maybe send you a chat and type that out for you. But that's a good website to see the listing of all clinical trials that are happening in the country. And you can select the types of trials that you want, or the types of the condition that you want to look for. So you can customize your search. So you can type stem cell therapy or PRP, and then you can type degenerative disc disease, and then it will list all the actively recruiting clinical trials or the completed clinical trials, and it's got information on the company that does it. So you can contact them and ask them if you're a good participant for the study, or if you can qualify for that study. So clinicaltrials.gov. I don't know of anyone right now personally that's actively recruiting in San Diego, but that would be a good place to start. I'm hearing that PRP and bone marrow therapies provide slow and steady improvement and slow reduction in pain. What type of pain management is done in the interim? Very good question. So I have patients that come to see me, and they're in a, what we call a hot discs or a hot nerve, wherein you have active flared up symptoms, and that is actually not the perfect time to do these therapies. Usually what I do is I try to calm down the symptom first, whether that's an epidural steroid injection or physical therapy or rehabilitation. Most of the patients that come to us for treatments have already tried all these standard treatments. But for those of you that have not, that are seeing us for the first time, you just had the injury, you haven't had any treatments at all, our course is to do the standard treatments first. You got to start with the basics. You got to start, spinal strengthening, flexibility, decreasing the inflammation. So whether that's through injections or medications or other adjunctive therapies like acupunctures, we try to control the symptoms first and get you stable, because as you said, these therapies take time to kick in. It could be 4 months or 6 months, which is typical for the spine, or in some patients, it could be 1 year. But it is, as I said, a slow, gradual improvement in symptoms. You're not going to wake up and say, oh, I'm 100% better. You're going to notice that maybe, 4th month, oh, now I can tolerate sitting better, or now I can bend forward and not have a lot of pain. So it's slow, gradual improvements over some time. Again, as I said, our average is about 4 to 6 months, wherein patients can actually say, yes, I'm, significantly improved. There's a question here regarding amniotic derived stem cells. There's really not a lot of clinical trials that has been published regarding this. There's probably one clinical trial that I know of that has one patient in the study. It was a case report using amniotic derived stem cell. So not a lot of data. So I can't comment on that. FDA is not allowing us to use any allogeneic source or biologics that are derived from outside of your body. So we're not doing those procedures. Again, a very limited data as of right now. Wow, great questions here. They just keep on coming. I love it. All right, let me go to the chat. There's more questions in here. How do you determine which disc is causing the pain? So there are specific clinical symptoms or presentation that are indicative of disc pain. So we get that from either your medical history when we interview you and talk to you about what's causing your pain, or other sources of information that can give us data. There's some data based on what we derive from examining you in the clinic that will give us a clue as to whether your disc is causing the pain. There are diagnostic procedures as well that can objectively determine if the pain is coming from your discs. So there is this procedure that's called discogram or discography, wherein we inject a needle into your discs and inject some contrast study and basically try to recreate that pain in your discs. And if you say that, yes, that simulates my pain, then that's a positive response. But that's called a discogram. That's an objective study. So yes, there are ways wherein we can determine if the pain is discs mediated, or if it's coming from somewhere else. Maybe it's coming from your joint, or maybe it's coming from your muscles, or maybe it's non-orthopedic, but I think that's where the clinical examination and history is important. What if the MRI is inconclusive? That is most of the cases, is that the MRI doesn't really tell you the whole story, right? It will just give us an idea to see how severe is the degeneration, which areas are degenerated. Um, and it also rules out, I think most importantly, all the red flags. We want to make sure you don't have cancer or any abnormal mass in your spine. We certainly don't want to inject your spine if you do have cancer. We want to make sure that there's no fracture in your spine, that something is not out of alignment and unstable. So I think that's where MRI comes in, is not only does it show your spine in detail, but it also rules out all the other red flags that we don't want in your spine, and that maybe can give us information and determine if you're a good candidate or not. Does PRP work for annular tears? Yes. In fact, there has been research that has been published with regards to PRP healing annular tears. And annular tears are those tears in the outside portion of your discs, and they can be very painful. Having said that, I had patients who's got annular tears in probably 5 levels in their spine, and they have minimal discomfort. But if I have to choose which MRI findings would give me an idea of if that disc is hurting or not, it would be annular tear is one, and if these tears light up in the MRI on certain images of your MRI, we call that high intensity zone, or HIZ. Can these treatments cause further damage to the disc? That is actually a good question, and that is also something that we have asked ourselves. The needles that we use are small gauge, and when you get into the disc, does it create damage? Maybe it does. We don't really know. It hasn't been studied. But once you pull out the discs, because the discs is made of cartilage, usually the cells will just go into that area where the needle track is, and help with that healing process. So do I know the answer to that 100%? Probably not, but theoretically it can create damage. We haven't seen that in clinical practice, where in patients were actually worse after the intradiscal PRP, or have seen a new tear in the MRI after an intradiscal injection. We haven't seen that. But good thought. And it's something that hopefully we can study in more detail in the future. Does PRP work for disc pain caused by an instability? So it can work for disc pain, yes. But if you don't take care of what's causing the instability, then that disc pain can recur, or it can return. So it's important to figure out what's causing the instability. Is it out of alignment? Is it because the muscles that are supporting the spine are not strong enough, in which case you need a really good rehab program? Is it because you have an autoimmune condition that causes you to be stretchy or bendy, or have hyperlaxity of your ligaments? Then that's something that needs to be addressed. So you got to treat the cause of the instability in order for the cell therapy to be effective. All right, probably our last question here. How do you determine whether to inject into the spine or around the spine? Oh, I think I'm assuming that you're asking if we inject in the disc itself, or into the epidural space, or the space around the discs. It depends on multiple things. Depends on your symptom. If your symptom is more predominantly disc related, that will point us towards going straight into the discs. If you have symptoms that points out to some nerve irritation, that's something wherein we consider treating it with epidural injection wherein we inject in the space where your nerves are. We usually go for the less invasive option, and injecting into the epidural spaces and less invasive option. So for patients who has less severity of the symptoms and they don't have a huge disc bulge, epidural PRP is probably, or injection around the disc is probably a good option. Um, Otherwise, for more degenerated discs, then we go straight into the discs. Do we know when Dr. Rogers will return? Hopefully very soon. He is getting stronger, and he is trying to get healthier so he can come back in the clinic. He's doing really well, though. Thank you so much for your concern and for asking about him. He's rehabbing himself so that he can be stronger, and he misses all of you guys. He misses all his patients, and we'll keep you posted and we'll let you know how he's doing, but he's doing really well. All right, let's see. I think that was our last question. Thank you very much for joining me today. Lots of great questions. As I said, this webinar, we do it every second Wednesday of the month. And then we also have an Ask the Docs series every first Wednesday of the month, wherein it's just an open question and answer session regarding orthopedic topics, and we choose the topics every month. Next month we're not going to have an Ask the Docs series, so watch out for any future announcements, either in your email, or you can follow us in Facebook. We usually put our announcements of seminars in there, or in our YouTube channel, or our Instagram. So thank you for joining us. And if you have any more detailed questions, feel free to contact us or email us admin@sdomg.com, or call us in the clinic. Thank you, everyone, and have a great day. Bye-bye.